Thank you for joining this webinar. I'd like to introduce myself. I'm Dr. Nick Lake. I'm one of the clinical leads for the Sussex Mental Health Collaborative. I'm also the Director of Clinical Strategy at Sussex Partnership Trust. So what's this webinar about? It's an opportunity to really introduce and give you an overview of one of the most important pieces of transformation work we're going to be doing for mental health services in Sussex. And that's the transformation of our adult community services. What I want to do is give you a sense of why these changes are important. I want to describe what changes are going to be happening. I want to describe how we're going to go about making those changes and how you can get involved. And I'm also going to try and really bring this to life by giving what will be 6 case studies, 2 on service users and carers, and 4 brief ones on staff, which I'm hoping will really help you to get a sense of what the key differences are between how things have been and how we want things to be. I do want to say just 2 things before I get really and kick off into the details. The first is that I want to acknowledge that this work is already in progress in many areas. We're not beginning from ground zero. There's an awful lot of fantastic collaborative work happening, which we will be building on as we make these changes. And the second thing I want to say that when I talk about some of the challenges in current services, I'm in no way wanting to imply that there's challenges to do with our staff. We have fantastic staff working extremely hard, but we do have a system which is problematic. And I want to describe and give you a sense of those on this video. I'm hoping you will all recognize it, whether you're a service user and carer watching the video, whether you're a member of the third sector, or whether you're a member of staff in one of our statutory mental health services. Hopefully you can see the slides below. I'm not going to follow those slides in detail, but they will add additional points to the points that I'm making on the webinar. So let's get started. Why do we need a transformation of our adult community services? I think one of the good changes that has happened over the last 20 to 30 years is that as a society, we're increasingly aware of our own mental health, and we're aware that there are treatment options available to us if we're struggling. That is good news. I think one of the challenges, though, in that context is that we're less and less likely now to seek support for those difficulties from our friends or from the wider community. Instead, we're much more likely to seek support from specialist mental health services. And I think that would be potentially all right, although maybe not ideal, if those specialist mental health services were suitably resourced. But of course, mental health services, and I do want to say particularly services for children and young people, have been chronically underinvested in. The government recognises that, service users and carers recognise that, staff recognise that. So in practice, trying to seek support from specialist mental health services is a real challenge. Made worse, so I think, by the fact that these services have often sat in relative isolation from other care services. So mental health services have not been particularly well joined up with third sector care services, and mental health services have not traditionally been particularly well joined up with physical healthcare services. What's the consequence then of that? Well, I think, again, if you're a service user and carer, you'll recognise that the main consequence is it can be very difficult to get help. In primary care, and GPs we have to recognise support an awful lot of mental health need at a primary care level. Estimates over 40% of their caseload are mental health related. But GPs often have to manage those issues in relative isolation. When they do refer to ATSs, they come across the challenge in ATSs, which is that we have long waiting lists. And it is particularly difficult for staff, I think, in ATSs to manage those long waiting lists and large numbers of people coming in, their stressful environments. And as a consequence, I think resources get targeted more towards pharmacological interventions and keeping people safe than actually providing evidence-based treatment of the more social and psychological kind. It is a challenge, I think, across the board. The second thing is that there are often cliff edges between services. So IAPT has quite strict criteria. Those are our increasing access to psychological therapy services. But your ability to enter those services does depend on the nature and extent of your difficulties. And there are a number of people, and I will give an example shortly, who fall in the gap between services. And even when service users do access services, there are a number of times when people really report feeling that they're actively just being kept safe rather than necessarily able to access the interventions they really believe would make the biggest difference. So this is a service under considerable stress and strain. I think it's made worse by the fact that third sector services are not necessarily joined up with statutory services. Sometimes they're parallel services. Again, there are, I think, good examples of where that is actually working well. There's often a limited offer to people when they're discharged from secondary care and acute services. We struggle to really focus on prevention and early intervention. And we do struggle, certainly from a statutory mental health perspective, to really support that wider community to play its role in providing support to people with mental health problems. And the two last ones I do want to point out in particular, the first one is because of that lack of join up between physical and mental health services, people do tend on average, if they have a serious mental health problem, to die between 10 and 15 years earlier than people in the general population. And the second major challenge for services is we are really struggling to recruit the numbers of staff that we need to provide safe, effective care. So that's the problem. That's the issue. This is the new model that describes how we want to do adult community mental health care across Sussex within the new framework that's been outlined by NHS England. And the real principle here is that we need to return to a model where people are supported and enabled to care for themselves and to live well within their communities, so that we're really supporting and enabling both that personal community, family, friends, neighbours, work colleagues, to provide support, as well as then that wider community. And the real change here is that if we're able to get to a stage where mental health care is not overly professionalised, but instead that wider community is really supported and enabled, re-enabled really, to provide care for people with mental health problems at the most core enabling level, so that enabling and care is provided at that level, it frees up our resources then in statutory services to then be offering more treatments, not having to provide the care, not having to continually focus on keeping people safe, although that remains an important element I'll come to. And by having more treatments available, hopefully again, that supports and enables that individual sitting right at the centre of that to be able to more effectively manage their own mental health difficulties within that community that is supporting them. That is what we need to move to. And in order to do that, what we're going to be doing is more clearly delineating two components of current adult community mental health services. We're going to be separating out the first, which is the emotional well-being service. Those are the core mental health services, and they will be wrapped around local neighbourhoods and local PCNs, that's primary care networks. They're groups of GPs that come together. And those local services will be really focused on supporting and enabling that local community provision and really supporting and enabling the join up of physical and mental health care. Specialist community mental health services wrap additional support around those core emotional well-being services when it is needed and when it is required. So it's an extra layer that comes around. People are not referred from one service to another service, having then potentially a different care coordinator, different practitioners. People always remain part of that emotional well-being service, and that care then is then put around them when that is required, and typically for a time-limited period. Let me talk through then the emotional well-being service and just the key elements of that. As I said before, its primary aim is to enable people to live well in the community, to really connect up third sector provision, community-based resources with some evidence-based specific interventions, particularly psychological interventions, provided through that core team. Those emotional wellbeing services will be integrated with other types of local community services to support the integration of physical and mental health care, and PCNs and GPs will take a real leadership role within them. Care within that community, again, should be really offered from a broad biopsychosocial perspective, with a real focus initially on developing a formulation of a person's difficulties, rather than, and when I say formulation, the word trauma-informed care is really important here, rather than jumping immediately to a more diagnostic approach. That may be important later, but that isn't the core focus of the emotional wellbeing service. Within the emotional wellbeing service, you will have associate care coordinators, they could be peer workers or others, whose responsibility is to really support and enable people to join up and connect to those resources that are out there in those local community groups. And a key principle of the emotional wellbeing service is that you join it through any part of that connected, interrelated service pathway. So, for example, I'm going to pick up the example of John, the veteran. In the new model, what we would like to be able to see is if John joins as his first point of contact the Breakfast Club for veterans, he will automatically be registered as part of the emotional wellbeing service. He will be given a patient portal where his details on an app on his phone are accessible, and those describe the type of treatment options and care that can be added on if that is necessary or required. And that Breakfast Club becomes much more than a Breakfast Club. It becomes a real resource and support for people, and for veterans in particular in this case, obviously, with mental health problems, supported by specialist community CPNs and some psychological support that comes in and supports the staff running those services when that is required. So you access the support immediately, and you're part of the mental health service immediately in that front door. In order to develop that sort of interconnected network built around these emotional wellbeing services, around PCNs, IT is key. We need a connected IT infrastructure that shares the same information and outcomes across all services, so we can compare and contrast pathways. It's joined up. You don't refer from one service to another service. This is a joined up integrated single service, really supported and enabled by digital passports. And GPs, psychologists, primary care health workers will all be play important roles in providing overarching governance, training and support to this system. That's how we ensure that this system is safe. It is community-based, it is really supportive and enabling, but we do also need to make sure that when people's needs require escalated care, that happens. Wrapped around then those core emotional wellbeing services are our specialist community mental health services. Those specialist community mental health services, we hope, because more of the enabling and supportive interventions can be provided within the emotional wellbeing service, will be freed up to focus more on the specialist care and treatment that may be required when people's needs escalate. And that criteria for that support will be based on a combination of someone's mental health risk, the complexity of their presentation, and the level and intensity of that support that is required. But the key here is that these interventions should be time limited, should absolutely be focused on providing support that enables people to move back into care being provided by that emotional wellbeing service. And those treatments really need to be as evidence-based as we can make them. And you don't refer to that specialist community mental health service. It is part of an integrated service, but that support is wrapped around when it is required. Those specialist services, and particularly the community sort of team element of it, will have an increasing role in leading and supporting the effective coordination of resources across the whole mental health care pathway. And when I mean that, I mean across both the emotional wellbeing service, the specialist community mental health service, urgent care services, and acute care services. In other words, all the way from the third sector, early intervention and more preventative work, all the way to hospital care. Why are we saying that those community mental health teams, and particularly the consultants and the managers within them, need to be able to effectively coordinate and oversee care across that pathway? Well, it's because we want that pathway to really flow. We want to be in a situation where a single team is coordinating and trying to use the acute crisis community resources in the most effective way and in the best interests of service users and carers. So in effect, and I'm going to give you an example of Mira here in her new role with part of the specialist mental health services as a consultant psychiatrist, she might spend the first half hour with one of the senior managers in front of our new digital tool supported by Power BI, really looking at the flow that currently exists across the pathway in the areas and neighbourhoods for which she has oversight and responsibility. The number of beds, the crisis resource, the community resource, and she will be reviewing and comparing that data and preparing to take that to the meeting where some of the tricky cases and some of the issues that need resolving can be worked through. In that way, it's possible, for example, for a community team holding someone who is really at risk to be working very closely with acute care to actively pull maybe one or two people out of a bed into being supported in the community to enable the person who is at most risk to access those beds. It is about much more effective join up of those resources. And that's also a key change for the specialist community mental health service element. What are the key enablers to doing things differently? The first has to be about developing and increasing that community and voluntary sector workforce, their ability to innovate and their ability to really support and enable that wider community to take on the roles we want them to take on. The second is digital. So much potential for digital, not only in terms of providing more effective join up, but also in the types of clinical innovations, the digital passports, the use of apps to support psychological interventions. There's a huge amount. Our new service will be led by its digital innovation. Third is workforce. We can't still keep recruiting or trying to recruit the same people for the same roles. We know there are not enough staff out there. This is a real chance for us to innovate around our workforce, and particularly to be innovating around roles that support that wider community integration. And the final thing I do want to mention is estates. If we're really going to get this join up between physical and mental health care, and we're really going to create these new emotional well-being services that are really support and wrapped around those local communities, we do need to be able to staff and co-locate staff within those local communities. So estates issues will be really important for us to tackle and address. The core assumption here, and this is really important, is that there isn't a difference, as there currently is, between care provided in primary care and secondary care. This is actually much more joined up and integrated. You don't refer people from one service to another to then get bounced back. You always remain a member of that core mental health services, again with that additional support wraparound when required. I think I've probably made that point a couple of times previously, but it is the key element, I think, of this work. What are some of the key differences then, before I just go back to those case studies? We have got examples, I think, of care between third sector, statutory services, physical healthcare services that have become a lot more joined up. We really need to build on those and be developing single integrated care pathways. We do, as I said before, need to make sure that services become really locally tailored around their communities. The community will need to be enabled to take a much greater role in supporting people with mental health problems, particularly in the supportive and enabling interventions. That should then free up specialist community services to provide more evidence-based care and treatment, particularly. People should be able to enter the emotional wellbeing service at one of a variety of points, and immediately you enter that in any one of those, from a third sector support group all the way through to acute care. When you enter the mental health care system, you immediately become part of the emotional wellbeing service. And I'm going to give you the two examples, the case examples, in a minute for the difference between how things were before and how we want them to be moving forwards. That focus again around PCNs, we also believe, is really important in getting integrated physical and mental health care right, and people with particularly SMI should expect to get much more integrated care consistently within our new model. We want to make sure there's much greater availability of time-limited psychological interventions. That's a clear ask from NHS England, or requirement from NHS England. And I think the last thing to just really again re-emphasize is that care is always coordinated from the emotional wellbeing service. So no matter people going into acute, crisis care or others, the continuity of care with that person must remain in place. What does that mean then for some of our other case studies? Let's go just back to this. Let me return to, and I've lost it, I'm afraid, in my presentation, so hopefully this is still working. I want to go back to John. John is the veteran, do you remember, who struggled to get care, bounced between IAPT and secondary care, veteran with experience of service in Afghanistan, struggling with depression and PTSD. Under our new community services model, his first point of contact might well be the Breakfast Club for veterans. That breakfast point is seen as the suitable first point of contact. When he begins attending, not only do the peer workers and that wider community serve to provide some immediate support for him around his difficulties, That group have also been trained up in mental health first aid to give that first stage therapeutic input to enable John to begin to get back on his feet again. They will also have been trained and understand and know when to escalate care. And John, and the fact that he's got his digital passport already from having entered the Breakfast Club, also knows the care that he can access if he needs to. So let's imagine John is connected in and begins to talk through and hear about other people's experiences, what's been helpful for them, for the peer workers. Maybe he decides he does want to access a psychological intervention for the trauma. Again, under our new model, he is already a member of the Emotional Wellbeing Service. He talks to his care coordinator. Care coordinator speaks to the psychological provision that exists within the Emotional Wellbeing Service. There is a conversation about needs, and John is immediately referred to someone who can provide him with the psychological care that he needs. In fact, I shouldn't be using the word referring. That person wraps that additional support around when that is required. The Emotional Wellbeing Service and IAPT, because there's much clearer join up between the psychological provision, we're not getting this stage where care is bounced between different parts of the service. And if John did need more intensive, perhaps psychiatric support or periods of crisis, his connection with the Emotional Wellbeing Service and his care coordinator in that service would never, ever go away. He remains a member of that Emotional Wellbeing Service through his whole mental health journey. Let me just talk about Sarah, who is our 53-year-old woman with bipolar disorder. The difference in this service model is that while she is an inpatient, she becomes a member of the Emotional Wellbeing Service. And the care coordinator, again, when I talk about care coordinator, I'm not talking here about a nurse, or I'm talking about an associate care coordinator who might be a peer worker or other member of staff from that Emotional Wellbeing Centre. They would go to hospital and immediately connect up with Sarah, so that Sarah automatically makes contact and becomes part of the Emotional Wellbeing Service, even as an inpatient. And that, theoretically, at least, should really help in supporting effective transition out of acute care back into the community, and leave Sarah with an experience of really joined up care, not the fragmented experience that she might be receiving now. In addition, not only then when Sarah is discharged back to primary care, we also can ensure that the responsibility for the care doesn't just remain with the GP. There is that wider network. Sarah is linked in to the third sector and community resources that are available to her. And actually, this is a key difference. If there were, as we would want, more availability of psychological interventions, one of the areas is around psychological interventions for SMI. We know that cognitive behavior therapy is a really important part of a preventative approach for people with bipolar disorder. And because we've prioritized that within the Emotional Wellbeing Service, as part of the discharge to care, she's able to access it. So I'm going to pick up what also the experience might be for our 4 staff members working within this new framework. The first is Philip, our CPN. Because Philip no longer has such a large caseload, is no longer having to provide all the supportive and enabling interventions, Philip is able to focus on 2 things in particular. He's able to actually use the CBT skills that he's been developing more specifically, so he can focus more on providing specific evidence-based interventions. But he also has a real interest in taking on the expert care coordinator role. But that expert care coordinator role is different from the previous care coordinator, where he was having to manage everything himself. As an expert care coordinator, his job is to connect with that much wider community resource when people enter a period of crisis, so that in that period of crisis, that wider system can still hold, contain, and manage the emotional distress being experienced by that person. Someone escalates in crisis, they don't suddenly then have to form a whole lot of relationships with a whole bunch of new people. Instead, they maintain their relationships with the people they're connected to, but Philip comes in and wraps that additional level of care and expertise around him when that is required. Mira, as the consultant psychiatrist, we're hoping will be feeling very different about her job and her work, because Mira now is really leading a whole system. So not only is she now responsible for the corrective coordination of sort of movement of people across pathways, but Mira actually is now going out into the community and acting as a real consultant to that wider community, providing advice, support, particularly to GPs who are taking a leadership role within the emotional wellbeing service. And again, Mira no longer has a long list of outpatient appointments where she's needing to just review people's care, because the review of people's care happens within the emotional wellbeing services by associate care coordinators who are supported and enabled to make those decisions and to escalate when that is required. What about Jenny as the consultant or as the principal psychologist? Jenny actually is also feeling very different about her job. Not only is there increased availability of psychological therapy resources, particularly within the emotional wellbeing service, not only that, but actually the whole emotional wellbeing service is developing a more formulation, trauma-informed approach to care. And it is her job within that emotional wellbeing service to support the training, development and articulation of that trauma-informed and psychologically informed approach to care. She also goes out and visits community teams and advises and support people not only on psychological first aid, but also about how and when to escalate people's care when that is needed. And finally, what about Archie? He's our veteran. Well, the Breakfast Club is thriving. It's more than just a breakfast club now. It is a really effective third sector support service for people with mental health problems. It's fully integrated into the emotional wellbeing service. It is part of it. And the IT and digital connections, as well as the regular advice he receives from staff members within the emotional wellbeing service, means he feels much more confident and much more enabled to provide the support and care that he feels is appropriate, but also to escalate that when it is required. So I'm going to now finish the presentation. I'm hoping that you have got a really good sense of the changes through those case studies. I do want to just end by saying what next. The thing that's really important to note is that at a Sussex-wide level, we have a programme of adult community mental health transformation. We know we will be receiving funding, quite significant additional funding from April next year to begin to take forward and develop these ideas. We know that the engagement with us, our colleagues in GP and primary care services is really important. And we know that service users and carers have to be right at the heart of leading these changes, and in particular, helping to really articulate and develop what a trauma-informed approach to care within those emotional well-being services to make sure we're really clear what that looks like. If you do want to get involved in any way, then the person to contact is Neil Johnson. So neil.johnson@sussexpartnership.nhs.uk. He is leading this work stream at a programme manager level, and he will be able to connect you up with different work streams that are continuing to further develop and articulate the service model for each of each of the parts of the community mental health transformation process that I've articulated here. So please do get involved if you want to and are able. We will have an opportunity at another time on a webinar, on a live webinar, for people to ask any questions. But for now, thank you very much for listening, and I hope if you want to be part of it, you will let us know. Thank you.